Hello everyone, today we are going to talk about the anatomy of the thoracic viscera. Viscera pertains to the organs. And remember, we are going to be learning always the anatomy of a given part, followed by the radiographic positions that go along with that part. So we will dive now into the anatomy of the thoracic viscera. So the first thing we want to talk about is body habitus. Body habitus determines the shape, the position, the movement of the internal organs. We're going to look at a diagram on the next slide. It says the following diagram shows the general appearance of the thoracic cavity of different body types. So here we have the four body habiti. Sthenic being the average, a little bit bigger than. We've got hypersthenic, a little bit smaller than the sthenic would be hyposthenic, and then the thinnest or most slender build would be the asthenic individual. I always like to take a look at the two extremes, the hypersthenic and the asthenic. When we look at this, what do you notice about the hypersthenic person? What you should notice is that the lungs are going to be smaller and more compact because the diaphragm is higher. When we look at the asthenic, the lungs are long because the diaphragm is at a lower position. Now that's going to come into play when we are going to be taking x-rays of the chest, especially what's called the PA of the chest, the posterior to anterior projection of the chest, because it's going to allow us to determine, are we going to put our cassette into the bucky crosswise or lengthwise, or are we going to turn the detector crosswise or lengthwise? For the hypersthenic, so we don't clip any of the lungs, we're going to put the cassette crosswise. And for the asthenic, we're going to put it lengthwise because we need that length for the longer lungs. What is the thoracic cavity? It's bounded by the walls of what we call the thorax. It extends from the superior thoracic aperture to the inferior thoracic aperture. The diaphragm is what's going to separate the thoracic cavity from the abdominal cavity. Now, as we go along with this anatomy, I'd like you to have open your textbook to the chapter on the thoracic viscera. It's actually the chapter on radiography of the chest or the radiography of the thoracic viscera. The thoracic cavity contains the lungs and the heart, the organs of the respiratory system, but also the cardiovascular and what we call the lymphatic system that we'll be learning about soon. The inferior portion of the esophagus and what's called the thymus gland, which is in the what we call mediastinal area. And there's three separate chambers. There's the pericardial. Peri, remember, means around, cardial pertaining to the heart, so that area around the heart. And then what we call the right and the left pleural cavities. The pleural cavities are where the lungs are going to be housed. Between that, then we've got the mediastinum, media meaning in the middle, which separates these two pleural cavities. And it contains all of the thoracic structures except for the lungs and the pleurae, the coverings of the lungs. So everything in the middle, and we're going to talk about what's in there, is considered to be the mediastinum. Your lungs, though, and the coverings of the lungs, the pleurae, are not part of the mediastinum. So here we have a diagram. We've got the heart right in the middle. And this is going to be important for you to understand because when we're going to look at a chest x-ray, we're going to see various shadows and various densities. The heart's thick. It's going to show up as a white area on our radiograph because it's going to absorb the radiation. And then we've got our right and our left lungs. And because they are more air-filled, x-rays are going to get through and they're going to penetrate. They're going to hit the detector and it's going to cause density or darkness on the radiograph. You can see we've got a tube coming down called the trachea. That's going to allow us to breathe. And then we've got this very large muscular partition, which is going to partition off the abdominal from the thoracic cavity, and that's called the diaphragm. Of course, it says here the ribs have been moved, because obviously on a real person you'd have the ribs then wrapping around, attaching to the sternum. So when we talk about the respiratory system, what are we talking about? Well, we're going to be talking about a tube that's going to allow us to get air into our body, into our lungs. The oxygen is going to be taken out, and then we're going to expel the carbon dioxide, the waste product. So when we think about breathing, okay, the first place the air that we breathe is going to be into our nose, or our mouth area. When we breathe in through our nose, the air first would go to what is called the nasopharynx. There's three parts to what we call the pharynx. As we continue to breathe in, the air goes from the nasopharynx into the oropharynx and then into the laryngopharynx or laryngeal pharynx. So three parts to the pharynx: nasopharynx, oropharynx, and laryngopharynx. The air continues to go down and it goes into a tube that's called the trachea. The air continues on its journey toward the lungs. It separates and it goes into what are called the bronchi, and we've got a right and left side to our bronchi. And then, of course, we've got two lungs, the right and left as well. Let's talk a little bit first about the trachea, so this tube that's going to go from the pharynx down then into where it splits before becoming the bronchi. It's a fibrous muscular tube with about 16 to 20 C-shaped cartilaginous rings in its walls for strength. These cartilaginous rings also are there so that the trachea doesn't close up. Okay, we want to make sure that these cartilaginous rings keep that tube open. It gives you some measurements here. It's not the widest of tubes, it's about a ½ inch in diameter. It's about 4.5 inches in length, and the posterior aspect is flat. So you've got these C-shaped cartilaginous rings in the front, and the back section or the posterior section is flat. It does lie in the midline, and it is anterior to the esophagus. Now that's important to note because sometimes you see in register review books or sometimes even on exams, which is more anterior, the trachea or the esophagus. Your trachea is anterior, and then behind it is the esophagus. The carina. The carina is a hook-like process on the last cartilage. It's that point where the trachea, what we call bifurcates or separates into two tubes. So the trachea bifurcates or divides at the carina into what is called the right primary bronchus and the left primary bronchus. So you can call them primary or main stem, main bronchi. Each primary bronchus then enters the corresponding lung. So the right primary bronchus would bring air into the right lung. The left primary bronchus is going to bring air into the left lung. A very important note here. The right primary bronchus is shorter, it's wider, and it's more vertical than the left. Now, why is that important? Well, sometimes people, especially children, aspirate something, which means that it gets into our respiratory system from our mouth. A coin, for example, a child might have and aspirates it, or even an adult that it has aspirated something. It's more likely to go into the right primary bronchus versus the left. Why? Because it is shorter, it's wider, things can go into it easier. So this position then and its size make it easier for foreign bodies to enter the right bronchus. And a foreign body is basically anything that shouldn't be there. A coin, a piece of something that you've eaten. Okay, and instead of going into the esophagus, it went into the respiratory system. there are subdivisions of what we call the bronchial tree. So we've talked about the main bronchi. Those are coming down. So you've got the trachea. The trachea then bifurcates or splits into the main bronchi, right and left. These bronchi, same tubes, are now going to split into what are called secondary bronchi, or what is referred to as the lobar bronchi. The lobar bronchi are termed this because they are going to bring air into different sections of the lungs that are called lobes. After the bronchi are in the lobes, they get even smaller, and these are called tertiary bronchi or segmental bronchi. These become smaller to become what are called bronchioles, and smaller to become terminal bronchioles. So it's this tube that becomes smaller and smaller and smaller. And eventually these terminal bronchioles are going to communicate with what are called alveolar ducts or alveoli. And the alveoli are what are referred to as the functional unit of the lung. So that's important to note. The alveoli, or alveolus singular, is the primary way in which oxygen and carbon dioxide diffuse into and out of the tissue, or into and out of the blood, I should say. So alveolar ducts end in alveolar sacs. Walls of alveolar sacs are lined with alveoli. And as I mentioned, oxygen and carbon dioxide are exchanged by diffusion in the alveoli. Now, how many are there? There's millions. There's millions of alveoli in each lung. Now, obviously, if there's millions of them, they're very, very tiny. In fact, they are microscopic. But if you look at the drawing here, you've got the terminal bronchiole, and then notice it's almost like, it always reminds me of kind of like clusters of grapes, it looks like, right? But it's a hollowed out area. Air gets in there, and then wrapped around the alveolus is venules and arterioles and what are called then capillaries. And it's through this thin wall of the alveolus and the thin wall of the capillary that the oxygen can diffuse and the carbon dioxide can diffuse. So we bring oxygen into the blood, and at the same time, we're taking out the carbon dioxide. Now, the physiology of that is beyond the scope of this lecture, but certainly when you take anatomy and physiology, or if you've taken anatomy and physiology already, you probably have talked about the diffusion of gases and how this could occur then in the alveoli. So here's a picture showing you, when we look at it, up at the top here, we've got the larynx. Now, the larynx is going to be important, okay, because this is going to be our voice box. It's where our vocal cords are at. Then you've got the trachea. The trachea comes down, you get to the carina, and it splits. Then you've got the main right and left bronchi, and then those are going to split further into the lobar bronchi, eventually getting to the terminal, what are called bronchioles, these little tiny, tiny bronchi, and then they're going to attach then to the alveolar ducts. So although you might think the lungs are like balloons where we breathe in and out, they kind of are, but they're also very, very vascular, which means they've got a lot of blood supply to them because, like I said, around the alveolar sacs, you have these very small blood vessels that are kind of wrapped around at a microscopic level. So lots of blood within the lungs as well. Let's look at this chest x-ray. Okay, well, first of all, let's talk about the lungs. What are they? They're the organs of respiration. Now, I want you to look at this chest x-ray. Remember, I told you that the heart, which is in the middle, is going to absorb the radiation, so it comes out as kind of a white area. Hopefully, you can make out the heart there. And then when we look to the sides where the ribs are, you see it's darker in there. That's going to be the air, but there's also little tiny bits of gray scattered throughout. That's the lung tissue itself, which we refer to as lung parenchyma. And then you've got different parts to the lung. Okay, this is a PA of the chest. It is hung correctly because you always hang a radiograph with the right side of the radiograph to your left and the left side of the radiograph to your right. Now, I know that might not make the most sense, but you'll be covering that a little bit more in another course. But when you hang a radiograph, the right goes to your left and the left goes to your right. Now, I'm saying hanging, it's kind of going back to when we used to put radiographs on a light box, but it's the same way when it appears on your computer screen. You want to make sure that the orientation of the radiograph is always correct. When we look at this, if you look, you can see the spine coming down right in the middle. And then coming from each side, you've got two bones that are coming across up at the top. Those are the collarbones, which are called the clavicles. Above that area then, above the area of the clavicles, you've got what is called the apex of the lung, or plural apices of the lungs. So that area above the clavicles is the apices. Inferiorly, all the way down where it starts to get all white, that area is called the base area, the base. Rest obliquely on the diaphragm, so it kind of is an oblique angle in the body. It's lower in the back and on the sides than the front. And you'll see that when we study chest radiography and you look at the lateral view, you're going to see that the back is actually lower than the front. Now, what's circled on here is something that's called the costophrenic angles. Now, your costophrenic angles are going to be very important because when we do radiography of the chest, we always try and have the patient in as upright a position as possible. When patients are sick, sometimes they get fluid in the lungs, and if I'm having the patient in an upright position, where's the fluid going to go? It's going to go to that lowest level, which is the costophrenic angles. You'll hear the text when you go to clinical say, oh, did we clip off the CPA? What does that mean? CPA stands for costophrenic angle. When you're taking a chest x-ray, you always want to make sure you don't clip any anatomy, so you've got to get all the way from the apices all the way and including the costophrenic angles. The medial border is called the hilum. So the hilar area is that median area, the medial border of the lungs. One thing to note, the right lung is shorter than the left. Why? Because we've got a very, very large organ that is right under the right hemidiaphragm. Hemi means half. So if you think about the whole diaphragm, half of it, you got the right hemidiaphragm pushed up because the liver is underneath it. Okay. When we breathe, okay, the diaphragm moves inferiorly during inspiration. So when I take a deep breath in, my diaphragm goes down. When I let all of the air out, that's called expiration, my diaphragm comes up. So when I breathe in, the lungs fill with air, they push the diaphragm down. When I breathe out, less air, the diaphragm comes up. Each lung is enclosed in what's called a double-walled serous membrane sac. Serous meaning it's got some fluid to it. So it's kind of a slippery kind of membrane. And this sac is called a pleura. Now you've got two pleurae. You've got the inner layer, which is directly on the lungs. Okay, it's this. If you were to cut into the patient and you looked at the lungs, you would see this membrane right over the lungs. That's called the visceral pleura. An easy way to remember that, viscera means organ. Viscera means organ. So the covering that's right on top of the lung itself is called the visceral pleura. And then you've got another pleura which kind of lines the chest wall. And this is called the parietal pleura. So the visceral pleura, this covering right on top of the lungs, and the parietal pleura, which is against the walls of the thorax. Between them is a space, which we call the pleural space or pleural cavity. Each lung, as I mentioned, is divided into lobes. The right has 3 lobes, the left has 2 lobes. Now, how are you going to remember that? Well, I always tell the students, think about what's on the left side of your chest at the bottom, your heart, right? And that kind of takes up a lot of room, your heart, especially when we went back and looked at that chest x-ray. So because the heart is taking up room, you've got two lobes, not a lot of room. On the right side, you don't have the heart. So now you've got more lobes, you've got three. So 3 lobes on the right, 2 lobes on the left. Here are pictures that are actually from your book. What separates the lungs into individual lobes are called fissures. Fissures. So when we look at the drawing A there, okay, on the right, you've got the horizontal fissure. If you look at that, find horizontal fissure. And then you have another fissure, which is called the oblique fissure. Now on the left, we've only got 2 lobes. So what we don't have on the left is the horizontal fissure. If you look, we still have the oblique fissure separating the left lung into the 2 lobes. The mediastinum. We talked about the mediastinum, and we said that it's an area that's bounded by the outer area of the thorax itself. So what would that be? That would be the sternum anteriorly, your breastbone. Back area would be your spine, and then your lungs laterally. In fact, we refer to this as the bony thorax, and we'll cover the bony thorax as we continue in the curriculum when we study then ribs and sternum. So sternum anteriorly, spine posteriorly, and the lungs laterally. Well, what's in the mediastinum? Remember, we said everything, it's in the middle, except for the lungs, those are on the sides. Those structures are going to be what are called mediastinal structures. So that's your heart, the great vessels. Now, what do we mean by that? We mean you got your aorta in there, you've got your inferior vena cava, your superior vena cava, you've got the trachea, you've got the esophagus, you've got a gland called your thymus gland, a lot of lymphatics, a lot of nerves, fibrous tissue, and then some fat. So lots of things that are in the mediastinum. So the question, okay, so think about it, see if you remember, which lung then has 3 lobes? Which lung has 3 lobes? Is it the right, the left, neither, or both? So the clue here is to think about the sides and what's on there. The left side's got the heart, the right side doesn't, right? Left side has 2 lobes, right side's got more room, it can have 3 lobes, so the answer is the right. Okay, so which lung has 3 lobes? The right. Aspirated foreign objects are more likely to lodge in is it the right primary bronchus, the left primary bronchus, the carina of the trachea, or the esophagus? So think about it. What did we learn? We learned that the right primary bronchus is wider, right? Okay, and a couple other characteristics too. But the main thing is it's wider, and then it's going to allow things to get in easier. So your answer should be the right primary bronchus. The level of the trachea's bifurcation is and the answer should be, the area where the trachea bifurcates or splits is called the carina, B.